Our next speaker is Dr. Anto Joseph, who will speak about pre- and post-exposure prophylaxis. He is the MO in charge of ART Center, Government Medical College, Ernakulam.
Good afternoon, everyone. I'm Dr. Anto Joseph. I'm the medical officer of the ART Center here in Government Medical College, Ernakulam. And today's topic is pre- and post-exposure prophylaxis. Pre-exposure prophylaxis is something we've all heard of, but maybe we don't use it in our daily life because we might not have many patients to be prescribing it to. So I want to brush upon it a little bit in a concise manner, in a way which everyone can understand. So let's start with pre-exposure prophylaxis. Before starting this, we need to check the eligibility of the person. Do they need pre-exposure prophylaxis? So how can we get this eligibility? One, confirm they are HIV negative. Why? Because if the person is HIV positive, by giving pre-exposure prophylaxis, they could develop resistance in the future to ART medications. Two, are they at a substantial risk? Who could this be? This could be sex workers, or could be people maybe working in a high-risk environment where they are prone to occupational hazards and needle stick injuries. Three, if there is no other contraindications, either biological, toxic, or anything else, no other contraindications, and does not have current or recent within month illnesses. Why is this? This is basically we are going to assume that this person might be in a window period. We've tested them, they've come out as negative, but they are having these unexplained fevers or other illnesses within the last few months. And then we have to assess whether they are ready to adhere. Because anything PrEP or PEP only works as long as the adherence is good. Without good adherence, they could basically just be eating Tic Tacs. They'll have the same effect. And they should be willing to attend follow-up evaluations. So, according to National AIDS Control Organization India, we have basically a few scenarios in which we would recommend giving PrEP, and that is pregnancy and breastfeeding. Let's see in pregnancy which all situations. PrEP may be initiated or continued during pregnancy in women at risk of HIV acquisition. Now this could be a lady who is HIV negative. We've had such a case in which the husband was positive, the wife was negative, but they had a sexual contact after the wife delivered within 1 month. So the child became positive because of breast milk. There is about a 40 to 45% chance of transfer of HIV from a mother to child if the mother is not on any ART and she is basically breastfeeding the child. So this is why it is very important. We could consider PrEP if the wife can come and tell us. There are many instances in which the wife will tell us, this husband won't listen. She'll ask him to wear a condom, but he'll say he doesn't like to use a condom. Or this could also be used in sex workers who are pregnant, or anybody else who is pregnant but at a high risk. So that is why during pregnancy in these cases, we can advise them to start PrEP. If a serodiscordant couple desires pregnancy, so this could be a couple in which either the husband is positive and the wife is negative, or the wife is positive and the husband is negative. In such a case, we are not going to tell them, no, you shouldn't have kids. We should advise them on how to have kids safely, such a manner that the child remains HIV free. So what should we do? First of all, first advice we have to make sure is the partner good adherence. If the husband is positive and the wife is negative, we have to make sure the husband has good adherence and he's a stable patient. What does that mean? His CD4 has to be greater than 350. His viral load has to be less than 1000. Preferably, his viral load has to be called TND, which is target not detected. That is basically less than 20 viral copies. So first, that's the first step. What's the second step? We'll tell them to go see an OBGYN. So they can get their fertility tested, the husband's sperm counts, the wife's ovums or anything else that needs to be checked. That has to be done. And after that is when we start the initiation of PrEP. Ideally, the best case scenario is PrEP should be started 20 days before of unprotected sex. So that is why it may not always a good option for anyone involving in casual sex, but we want to keep the safety of the discordant couple partner as high as possible, which is why we say 20 days before unprotected sex. And this must be in the most fertile period and may be advised to the couple for increasing chances of conception. So then the question naturally arises, we've started PrEP. So when will we stop this PrEP? Ideally, we should stop this PrEP once the mother has conceived, or once she has a UPT or any other blood test comes in as positive. Now, breastfeeding. PrEP may be initiated or continued during breastfeeding in women at substantial risk of HIV infection. As the case I previously mentioned, even after delivery, because the partner may not be willing to use a condom, the risk of the mother getting HIV is high. So for those instances, we could prescribe PrEP. If a woman becomes infected with HIV during breastfeeding, the risk of transmission to the infant may be higher because of high viral load during seroconversion. Therefore, PrEP should be initiated or continued in women who are at substantial risk. Next, let's move on to the NACO recommended regimens. But I want to emphasize a point is that none of this is being provided by NACO at this time. But there is a chance in the future that they will. But these are the recommended regimens: tenofovir diproxil fumarate and emitricitabine, or tenofovir diproxil fumarate and lamivudine. You might notice that there is something called as tenofovir alafenamide and emitricitabine. This is usually what we see private doctors write. Why they write this is usually because tenofovir alafenamide does not have a renal toxicity, but it is not as effective as tenofovir diproxil. Why is that? So that is why it is not recommended in using for people who are IV drug abusers or people who are assigned female sex at birth. This is because tissue penetration of tenofovir alafenamide is low, especially in the vagina, blood and lymph nodes. So that is why whenever we will prescribe a PEP or a PrEP, it should always be tenofovir diproxil regimen, disoproxil regimen. Now let's move on to post-exposure prophylaxis. This is one of the most common stuff that we encounter as medical professionals working in a hospital or any other clinical settings. So what is post-exposure prophylaxis and who is eligible for it in the context of National Health Program? Post-exposure prophylaxis refers to the comprehensive management instituted to minimize the risk of infection following potential exposure of blood-borne pathogens including HIV, hepatitis B and HCV. Today we will be primarily focusing on HIV prophylaxis. And who is a healthcare provider? A healthcare provider is not only the treating doctor or the staff nurse or the attendant, it could be the police, it could be the caretaker, it could be the prison staff, it could be the firefighter. Any government official who is getting occupational exposure is eligible for this PEP. So let's understand the different types of PEP. There is obviously the occupational exposure and the non-occupational exposure. The occupational exposure refers to the exposure to potential bloodborne infections that occurs during performance of job duties, such as during suturing, while taking blood, or maybe administering any injections or medications. Exposure may place a healthcare worker at a high risk if it is maybe a percutaneous injury, a contact with mucous membrane of the eye or mouth, contact with non-intact skin when the exposed skin is chapped skin or afflicted with dermatitis, and sometimes even contact with intact skin when the contact is prolonged with blood or other potentially infectious body fluids. Non-occupational exposure refers to anything other than this. It could be sexual exposure, it could be sexual assault, it could be unsafe sex practices. Now, the risk of exposure is different for different body fluids. I know everyone knows about the ones which are considered at risk, which is at the far end. But what I want you to direct your attention to is the ones which are not at risk. This is what usually that is surprising to many patients and many healthcare professionals. The tears, the sweat, the saliva, the sputum, the vomitus, the urine, and even the feces. All these are not at risk unless there is visible blood. Does not mean microscopic blood, it is visible blood. So this is what we need to remember. So whenever such an instance happens, we don't have to rush and take PEP as long as this is a not at risk exposure. Now, HIV transmission risk is different by different routes. The highest always being blood transfusion, followed by sexual intercourse. Now, even in sexual intercourse, it varies the rate of transmission. Highest being for anal, the next for vaginal, and the last for oral. Injection drug abuse have 0.6%. Needle stick exposure has 0.3%, whereas mucosal membrane splash is only 0.09%. But here what we need to remember is, in a needle stick exposure, in our mind, it should not be only HIV. We should also be thinking of hepatitis B and hepatitis C, as they have even higher risk of transmission than HIV, and they stay reactive longer outside the body than HIV virus. So the risk of transmission is increased in the following considerations: a large quantity of blood, there is visible blood in the device, procedure that involves placing a needle in a patient's vein or artery, any deep injuries, recent seroconversion, that is when they are developing antibodies to the HIV virus. At such instances, the viral load will be very high. And also in exposure to advanced case of AIDS, because obviously during this time also the viral load will be high. So what to do in an exposure? First of all, don't panic. If you are at a hospital setting, you are generally safe, but we should not do panic and should administer first aid. What is first aid? Washing with soap and water. I know most of the wards there will be hand rub, which is more easily accessible, but we should go to the sink and use soap and water because it is much more better in removing the pathogens. But what we need to know all the time is, as long as we do not panic, we won't reflexively put our finger in our mouth, we won't rub the wound. Sometimes even they'll suggest not even to press the wound to clot it. They'll say let it bleed out naturally, or at least let it bleed for a little bit while we wash the wound with soap and water. PEP must start at the earliest, as soon as possible, preferably within 2 hours and at a maximum of 72 hours. So how will we manage such an exposed person? We have basically 6 steps. Step 1, manager of the exposure site, which is the first stage. Step 2, see if they are eligible for PEP. Step 3, we give counseling before starting PEP. Step 4, prescribing the PEP. Step 5, lab evaluation. Step 6, follow-up. So let us see step 1. First, skin exposure, basically a needle stick injury. If the skin is pierced by a needle stick or a sharp instrument, immediately wash the wound and surrounding skin with water and soap. Do not scrub, do not use antiseptics or skin wash, don't use bleach, chlorine, alcohol or betadine, and definitely do not put the pricked cut finger in the mouth in a reflex action. For the eye, irrigate the exposed eye immediately with water or normal saline. A good time period is at least 5 minutes. So a simple way is to sit in the chair, tilt your head back, put a basin underneath and irrigate the eye. If wearing contact lens, it is good to leave the contact lens inside as it forms a protective barrier over the eye. And once the cleaning is done, we can even reuse this contact lens as long as you have put it in the cleaning solution. Do not use soap or any disinfectant on the eye. Same for the mouth. Immediately, first step should be able to spit out the fluid immediately. Whatever saliva, anything you have, spit it out immediately. Rinse the mouth thoroughly using water or saline and spit again. Repeat this process several times. We may have to do it 5, 10, even 15 times. Do not use soap or disinfectant in the mouth and consult the designated physician. This is what happens all. So the next slide is quite interesting because this is the protocol developed by us at Government Medical College in collaboration with the Community Medicine Department, the Superintendent Office and the ART Center. If you direct your attention first, we have created a more streamlined approach to needle stick injury. So this is the protocol that is we following. So let us take a case in which a house surgeon has had a needle stick injury, maybe in the ward. So first, needle prick or blood splash. First we do what? First aid. Step 1 is done. Second is report to the control room of GMCE. These algorithms are placed all around the school. I've just blocked the number because we are live streaming. And next, the control room will take the necessary details, after which they will inform the hospital infection control committee. And the infection control committee will generally do the rest. They will help you in taking the source blood sample, taking the exposure blood sample. They'll help you in maybe filling out the forms and getting the emergency seal so that this test may be rushed at the serology lab if the ICTC is closed. So they will then inform the case to either Dr. Tina or to me, Dr. Anto. Dr. Tina is our nodal officer for needle stick injuries and I'm the ART officer. So once they inform, one of us will decide whether PEP should go or not go. So if PEP is not required, we'll just fill in the rest when of the source status and the exposed person status. And if PEP is required, we will initiate emergency dose of ART. First dose is always at the casualty if the ART center is closed. ART center is functioning from 8 AM to 3 PM. So anytime outside that, emergency doses are available in the casualty in enough numbers. So I would like everyone to please have a glance once more on this, because this is a very good approach that we've created where it is so streamlined. The only thing you have to do is call the control room. And these charts are available in all our wards, ICUs, labor rooms and casualty. So now let's move on to step 2. the eligibility of post-exposure prophylaxis. I'm sure you might have been familiar with this exposure code, source code charts. I know it seems a lot of arrows and boxes, but there's an easy way to remember this. So, any case, let's assess three things: the risk, the type of exposure, and the source. So, the risk: is the fluid at-risk fluid? Is it maybe blood, semen, or is it just maybe tears, saliva, urine without any visible blood? So, first we'll check if the fluid is at risk. If the fluid is at risk, obviously we'll go to step 2. If not at risk, no need PEP. Next, the type of exposure. If blood is falling on intact skin or no mucosal membrane exposure, then no PEP. Again, then the source. If the source is HIV negative, then once again PEP is not required. So this is an easy way for us to remember all this complicated stuff. In every other case, usually PEP is prescribed, except in a case in which HIV, the source is HIV positive, but they are virally suppressed and the exposure is minimal. Maybe not a big injury, maybe a small injury with minimal bleeding. You can see that here. Exposure code 1, it is when the mucous membrane or skin integrity is compromised, but there is a small volume of fluid drops short duration. Now, step 3, counseling for PEP. This is a very important part of give any PEP administration. It doesn't have to be done at the ART center. The casualty doctor can do it, the ward doctor can do it, even an OP doctor, anybody can do it. Why counseling is so important is, this medicine has to be consumed for 28 days. So they have to understand the need of good adherence, where it should be taken preferably at the same time every day. Preferably do not take any fatty foods along with it. Any smoking or alcohol should be ceased during this time period. It should be clear that the PEP is not mandatory, but it is something as a safer, because there will be some people who do not want to take this medication in fear of the complications. Most of the side effects are very rare. It usually goes to just nausea, dizziness, and some sort of form of gastritis. Now, he or she should be counseled on safe sexual practices till both baseline and 3 months HIV test are found to be negative. So, we do the first step HIV positive for the source and the exposed. Source is, let's say the source we don't know, unknown source. The exposed person is negative. Very good. They are eligible for PEP. Now, we have to tell them, during this months you are still at risk, because why? We are still in the window period up to a maximum of 3 months. We'll even repeat the test at 6th month also, just to be 100% sure. So during this time, they should not have any unprotected sexual contact. If any breastfeeding should be done, maybe avoid breastfeeding, and they should not try to get pregnant at this time. Documentation on record is essential of counseling, as it is important that we document that all the side effects, how to take the medication, and how effective the medication is being told to the patient. Now, step 4 is prescribing PEP. I've made a easy to understand table where we have all the PEPs, the preferred regimens and the alternate regimens. We most likely will not use the alternate regimens, as the preferred regimen is what is available in most hospitals. So let's see. It's quite easy to remember, because anyone older than 10 years and older than 30 kilograms has the same regimen. The preferred drug regimen is tenofovir, lamivudine and dolutegravir. You might have noticed this is the same drugs that are given in as a part of ART therapy. In an alternate regimen is where dolutegravir can be replaced by ritonavir boosted lopinavir, where we give 2 tablets BD, or it can be replaced with efavirenz. But I want to stress that efavirenz is no longer available in the national program, and ritonavir boosted lopinavir is also rare. Now comes the tricky part. Someone greater than 6 years of age but less than 10, or greater than 20 kilograms of weight but less than 30. For them, we give zidovudine lamivudine based drug along with dolutegravir. Here you can notice that dolutegravir is still adult dose that is being given, but zidovudine and lamivudine is going to be given according to the weight band. Now, zidovudine does cause bone marrow suppression, primarily macrocytic anemia with neutropenia. So any child who has hemoglobin less than 9, it is more safe to give abacavir. But the thing to notice about abacavir is, abacavir could have some hypersensitivity reaction, and if that is present, we should never re-challenge the drug test, as it may lead to death. And then we go to the final thing, which is children less than 6 years and less than 20 kilograms. For them, we use zidovudine and lamivudine according to the dosage as per weight band, and dolutegravir 10 mg, that too according to the dosage of weight band, because someone between 3 to 6 kilos will only use half a tablets. 6 to 10 will use 1.5 tablets. 10 to 14 will use 2.5 tablets, and 14 will use more. So that is why we should always do this according to the weight band. Now you might have noticed that it used to be written over boosted lopinavir here at this part, but now this has been changed universally to use dolutegravir in all forms of PEP, even in all forms of ART. The alternate regimen same as before. If any contraindications to zidovudine, we will go ahead with abacavir regimen. The first dose of PEP should be administered as soon as possible. We will try to advise them take it at the same time every day, and you should consume it for at least 28 days. Sometimes when we write it outside, a bottle has 30 tablets, no problem, let them take it 29 or 30, but it is as good as taking it 28 days. Now there are some studies that say if you take it for 21 days, you are reasonably protected, but it is better to go with the 28-day regimen. Now, step 5. This is where all the baseline laboratory investigations happen. This includes HIV, hepatitis C, HPSCG, RPR in case it's a sexual exposure, RFT, LFT, CBC, and RBS. So why do we need all this? Obviously to get a baseline on if there is any other pathogens or if there is any other potential toxicities. Because tenofovir is renal toxic. Dolutegravir has been known to have hepatotoxicity and increasing the blood sugar levels. Or zidovudine has been known to cause anemia. So for all these things, it is good to have a baseline investigations, and based on this, we will do the further follow-up. HIV test should be offered to the exposed person, as a positive HIV status may indicate the need to discontinue PEP. So if the person that we test who's got exposed, if they come as positive, then what they need is not PEP. What they need is ART, for which they should be referred to the ART center, so we may register them and start PEP. It is important to remember that the person exposed to the risk of transmission of HIV is also at risk of getting hepatitis B virus and hepatitis C virus. Absence of HIV test in source should not delay PEP. So this is when such situations in which patient വീട്ടിൽ പോയി അപ്പോൾ നമുക്ക് source test ചെയ്യാൻ പറ്റിയില്ല, but our same needle which prick കിട്ടി, so that we can call them, we'll ask them to come, but let's not delay initiation of PEP. What's the worst that can happen? We'll start PEP, next day we find out the patient was negative, we'll say okay, very good, no need to take PEP anymore, because even that first dose of PEP is very protective. Now, and sixth and final step is the follow-up. This is clinical monitoring done during PEP. We should monitor for acute seroconversion illnesses within 3 to 6 weeks. Usually we do it 4th week, that is 28 days after taking the initiation of PEP. If suspected, you should always refer them to the ART center, and during this time period you should ask them to avoid blood donation, breastfeeding, and pregnancy. The person should also use precautions during sexual relationships, and that has to be condom protection. There is no other maybe pull-out method or anything else which they will say. It has to be condom barrier methods of protection. So these are the blood tests that we will do following our baseline investigations. In weeks 2 and 4, we will continue the CBC, we will repeat the CBC, RFT, LFT, and RBS to see if there is any changes. If any changes are there, we might have to change the regimen, or we might have to give up on it altogether. Week 6, week 12, and 24. Easy way to remember is 6th week since the incident, 3rd month since the incident, and 6th month from the incident. We have to repeat the HIV test, and this is where at the ICTC. Always it has to be at the ICTC because triple test is being done at the ICTC, not just a single test. Now, so there are some instances in which we are not sure. For those instances, we will need an expert opinion. So if there is delay in reporting the exposure, so this is after 72 hours. Most studies have said after 72 hours, the efficacy of PEP is quite low. But if this is a healthcare provider, we can explain to them, look, the chances of PEP working are very low, but let's give it a try. I'm always of the opinion something is better than nothing. So let them start PEP. Unknown source. PEP is advised to take on a case-to-case basis, such as severity of the exposure, epidemiological likelihood of HIV transmission. So what they mean is maybe we should take the region into context, as in like maybe it's a district with high incidence, like maybe like Ernakulam, or maybe it's a state with high, if it's maybe in Kerala, they could say Kerala is a state with low prevalence, maybe they don't need. But basically that doesn't work in a large scheme of things, because most likely anyone with an unknown source will want PEP, and we should not deny that, because what if in some other instance they get HIV from some other issue, they'll come back later and say, you guys did not give me PEP at the time, that is why I'm HIV positive. Known or suspected pregnancies do not delay PEP initiation. Breastfeeding issues in the exposed person do not delay PEP initiation. The source patient is on ART or as HIV drug resistance, we might need to consult more senior clinician, because maybe we'll have to change from a first to a second line drugs for giving for PEP. Any major toxicities of the PEP regimen, minor side effects may be managed symptomatically. Major side effects, we might have to stop the medication altogether. Refer to expert if drug intolerance and non-adherence. Consult if in doubt or in complicated cases. This consultation usually we give to SASAP, which is the State AIDS Clinical HIV Elimination Panel. So they will decide. They have senior medical officers who will decide this. They are usually in centers of excellence and ART plus centers such as Trivandrum and Thrissur. Now, some people will ask, what about in the case of sexual assault? As part of the post-sexual assault care package, PEP is provided. HIV testing of the source patient should not delay the decision about whether or not to start the PEP. The starting PEP first if required, and then send the source patient for testing. Because like I said, what's the worst that can happen? They come as negative, we can stop the medication. In case of a high risk exposure from a source patient who is taking ART, that is basically they're on ART, maybe they're not virally suppressed, or maybe they have drug resistance, we'll have to consult a senior clinician and maybe change the regimen to a second line or even a third line medication. As per POSCO Act, all pediatric sexual assault cases need to be notified to the concerned authority or nodal officer in each state and city. Now, for completion's sake, I've also written how to take hepatitis B vaccine after an accidental exposure to blood. If they have never been vaccinated, give complete hepatitis B vaccine series, all 3 doses. If they are vaccinated but they don't know the titer or don't know the anti-HBs, give them a hepatitis B vaccine booster. And if they were vaccinated more than 5 years before, give them a hepatitis B vaccine booster. Anti-HBs levels greater than 10, there is no need for hepatitis B hepatitis B virus vaccination. But if this is not available, might as well go ahead with the hepatitis B virus vaccination. So, now I've told you all about PrEP and PEP. Now I want to tell you about something that is even more better than PrEP and PEP. Can anyone guess what it is? What is better than taking PrEP and PEP? Prevention, exactly. The most common sense thing that we should always think of, it is prevention. Prevention includes what? Universal precaution. That is us using our gloves, our goggles, our coats, our personal protective equipment. Primary prevention, what is that? Spreading awareness, asking people to use condoms, maybe taking PrEP. Avoid occupational exposure to blood and other potentially infected materials. So that is why during training we ask house surgeons to practice on dummies so as they don't accidentally prick themselves. Personal protective equipment wearing, and remember, always say no to recapping of a needle, because no matter how skilled we are, at the moment maybe there might be an adrenaline rush, there might even be anxiety during the time. A small gap can cause a needle prick, and then we'll have to go through all this to test the source. What if the source says we are not going to give our blood for test? Then we'll be even more tense. So better than that, no need recapping of needle, just discard it. So here are some of the universal precautions that can be used. Consider all blood samples as infectious. Actually consider all patients as potentially having HIV positivity. That is the best way, because if we consider everyone as potentially infectious, then we will be able to keep ourselves safe. Now there are some advancements in how to prevent needle stick injuries, and that is using a safer needle device. You can see I've shown 3 needle devices here. One is a syringe with a protective shield. The plastic shield slides over the needle and locks to escape the exposed point. Next is syringe with retractable needle. When an extra push is given on the plunger, the needle will retract. A third is a blunt tip blood drawing needle. So after drawing the blood, a sort of cylinder will pull up and make the needle no longer sharp and blunt. So these are recent advancements. They're probably very expensive and not going to be available at our government setting, but it is something to keep in mind as something for the future. So before we end, I just like to go through the care pathway for everyone once again. First step, we're going to go for assessment. In this, we'll do a clinical assessment of the exposure, the eligibility assessment, HIV testing of the exposed person and the source, provision of first aid in case of broken skin or other wounds. Next is the counseling and the support. Risk of HIV, the risk and benefits of post-exposure prophylaxis. We have to inform them about the side effects. We have to give enhanced counseling if post-exposure prophylaxis is prescribed, and specific support in case of sexual assault, as they might also need psychiatric support and counseling. Next is the prescription. PEP should be initiated as early as possible. Within 2 hours is preferable, with a maximum of 72 hours. A 28-day drug prescription is recommended for all age groups, irrespective of the ART regimen. And also these have to be written down in the PEP register. There's one available at the casualty, which is being controlled by the Infectious Disease Control Committee nurses, and one at the ART center, which we will control. And finally, the follow-up, which is the most important part, I would say, is because we have to follow them up at the 4 weeks after the infection, or 6 weeks after the incidence, 3 months and 6 months. After the 6th month, you can tell your patient with 100% guarantee, as long as you have not had any other exposure other than the ones we started with, you are guaranteed to be HIV negative. Don't fret about it and don't be anxious. So this comes to the end of my presentation. Thank you, everyone. I'd just like to reinstate, prevention is primary.
Thank you, Anto, for the excellent, crisp, and to the algorithm presentation of pre-exposure and post-exposure prophylaxis. Just wanted to say a few things. We talked about pre-exposure prophylaxis in pregnancy and in breastfeeding. Now, in Perumbavoor, etc., there are a lot of IV drug abusers. So most of them, they have no sexual exposure, it is IV drug abuse, and this is something that we can advise to them to start using pre-exposure prophylaxis. Obviously, it is not free. They have to pay for it, and it is expensive. Then there are people who have a sexually transmitted disease like syphilis, and we know that they've had it 6 months ago, or they are in the process of being treated. We can advise them to take the pre-exposure prophylaxis for them also. Coming to post-exposure, we have talked about healthcare workers. We are seeing a lot of patients who come to casualty after an accidental sexual exposure, and they come to us asking whether the drug is free here. But we don't give the drug free for patients who come from the community. It is only for our healthcare workers. So the advice that the casualty doctor will give is to come the next day to the ART clinic and start the prophylaxis at that time. And that's within 24 hours. So we are okay with that. And then Anto is informed, and then he will take over from that point of view. So this post-exposure prophylaxis that we have in the casualty is for our healthcare workers. Any questions that you all want to clarify or ask about this, because it's a very important talk. We are all prone for this. So, anything?
There is a second exposure.
We have to take it again.
You'll have to start again.
We have had healthcare workers who take it a second or third time, because we have had people accidentally being stamped on a needle. They have to take it again.
Do you take unnecessary PEP dose and then stop? Does it have to resist?
I don't think one dose will usually be safe, because it is always better to be on the safer side, because they say this first dose is just as important as preventing the transmission of the disease.
In terms of, you have to ungown, come out, get your stuff done. Basically, don't wait for surgery to be over. Hand over to someone else who's senior to you, or call someone who's junior to you. You have to unmask, ungown, come and do your bit.
What's the chance of
needle prick transmission? How much?
0.3% for needle string. Yeah, and mucus is only 0.09. So yeah, mucus is when an amniotic fluid. When they have an exposure to amniotic fluid just suddenly coming on their faces and all. The chances are 0.09. Wash, as you said. We don't say hand rub because it is a chemical and it may cause some reaction or inflammation in the local area. So that's why we say water and soap. Wash with water and soap.
As per our knowledge, no one. Studies have shown that PEP is about 80% effective. PrEP is even more effective. It's about 99% effective if all taken correctly.
Yeah, it's supposed to have a good coverage. 90% sensitive responsiveness is there to the drug. And TLD is the word, so it's a short one. It's easy to remember. TLD. Yeah. Any other clarifications? Thank you, then.
That is being done for this 1.5 months, 3 months, 6 months.
Yes, sir.
Which test?
We're doing HIV test at the ICTs.
Triple test.
Triple test. Yes, sir. basically covering the window period. We're doing it 6th week, 3rd month and 6th month. So we're covering as maybe a window period as long as 5 months as even being covered in this.
So after 28 days of treatment, we've got that period. The 3 months is there for the conversion that's happening, and then we're testing in the 6th month. So we will know.
No, somebody who is already negative, the patient is negative and
The source, that's an interesting part. What if the source is negative? But you are still, according to protocol, we don't need to start PEP. But if we think about it a little more, could be in a window period. So we should take a more detailed history. We should see if they are in a high risk group. What is a high risk group? It is basically a migrant worker, maybe a sex worker, maybe a truck driver. We should ask their sexual history. Have they had many multiple partners? Have they had many instances of unprotected sexual contact? We should ask, have they had any IV drug abuse history? If any of these come positive, maybe let's not take a chance and start PEP. That would be a better. Although according to the protocol, the source is negative, it has to be negative. But such things are usually kept under the discretion of the ART officer. We can go for that.
The protocol is formulated depending on the prevalence of that area. It is only formulated. That is why we say no need.
Thank you, sir. I kindly
Thank you, everyone.
request Suma ma'am to hand over the certificate. Sir.
Now let's move on to the last session. I would like to invite Dr. Preeti K to chair the next section. She did MBBS from KMC Mangalore 1996 and later a diploma in dermatology and venereology from KMC Manipal in 1998 and also DNB in dermatology from MCH Trivandrum from 2005. She is working in Government Medical College Ernakulam for the past 18 years and is currently the Associate Professor in the Department of Dermatology.
My department for giving me this opportunity to chair this session. Even though this is my first time, I'm chairing a session. So today's topic I'm chairing is changing trends in STI. And STI is dynamic. Sexually transmitted infections are dynamic. It is changing and it is evolving, and that is because of the different practices like casual sex. And you can see the students, they are studying outside, they are going away from home, and they are kind of doing occupations, and then the late night working hours. All this causing different sexual practices. So all this is leading to more sexually transmitted infections, and the type of infection is also changing. I remember when I was doing my DNB in Trivandrum in 2003. So when I was doing my DNB in Trivandrum in 2003 and 2005, I hardly saw a case of syphilis. It was all paper syphilis with VDRL positive, TPHA positive. But now I get to see a lot of secondary syphilis, primary syphilis. So the whole trend is changing. And it is quite alarming also because the increase in STI, it facilitates the transmission of HIV also. Now over to Dr. Deepa to hear the changing trends.
Now let's invite Dr. Deepa Agustin, who will speak about changing STI trends. She is the Associate Professor of Department of Dermatology of GMCE Ernakulam. She has 20 years of teaching experience. Her areas of interest are general dermatology, pediatric dermatology, and sexually transmitted infections. She is the coordinator of Medical Education Unit of Government Medical College Ernakulam. She has 10 publications in various journals and has held various positions in CMCE, IMA, WIMA, and WDW of IMA KSB.
Good afternoon, everybody. So this is the last session, and I'll make it short and crisp. As Dr. Preeti told, there is a lot of change in the incidence and prevalence and the pattern of STI post-COVID. So we'll just rush through what are the changes seen in the changing trends of STI. So as you all know, STI is sexually transmitted infection. Why study of STI trends? Because there is a rising public health concern, and STI, those patients with STI, there is increased chance of acquiring HIV. So it's linked to HIV transmission. So if a patient is STI positive and HIV negative, compared to HIV positive and STI positive, the STI associated STI is there is more chance of complications also. So understanding changing patterns is very important to decide the treatment gaps and to implement prevention strategies. So the global trend is over 374 million new cases of curable STIs annually worldwide, that is mostly syphilis and gonorrhea. And there is a rise in viral STIs like herpes simplex infection and human papillomavirus infection. This is a global trend, and there is a threat of antimicrobial resistance in gonorrhea. Now the trend of STIs in India, approximately, this is the statistics from NACO 2023, approximately 6% of adults are affected annually with sexually transmitted infections. And the high prevalence of STIs in the vulnerable groups like female sex workers, men having sex with men, and transgender persons. And there is a shift to viral STI in India also, that is herpes and human papillomavirus infection. Now, this is a study which is published in Indian Journal of Sexually Transmitted Infections, a study conducted by Dr. Ajit Kumar K. et al. At Calicut Medical College, Department of Dermatology, that is linear trends over 20 years in sexually transmitted infections among patients attending a tertiary care center in North Kerala. In this study, the sexual behavior pattern that is documented is almost 80.5% of men have heterosexual contact, and 15.5% of men are homosexuals, and 4.3% both homo and heterosexual. So in females it is 99.4% and 0.5% homosexuals. In 1998 and all, we never saw transgenders with STIs, but recently post-COVID we see lots of transgender cases also. So in this study done from 1998 to 2017, the STI prevalence is 47.3%, and among that the viral STIs were on the rise, that is herpes gentalis 39%, condyloma acuminata 37%, syphilis was 17.2%. That is, it was mainly viral sexually transmitted infections were seen during the initial periods, but later on there was a declining trend was noted. Initially in 1998, all these were common, but after that we saw a declining trend in the sexually transmitted infections, and later, recently, there is an increase in bacterial sexually transmitted infections. So HIV coexisting with sexually transmitted infections were noted in 6.4% of patients, and males outnumber females. And at the time of diagnosis, almost 71.1% had a prior diagnosis of HIV infection, and in 28.9% of HIV positive patients, the STI was detected during their evaluation of HIV. So this is a linear trend over the last 20 years according to this study done in Calicut Medical College. That blue line shows the total number of STI cases. So initially from 1998, there is a rise in STI. Slowly it's coming down, and gradually by 2017 it's again rising. So the bacterial STI almost steady, and the gray line shows viral STI. Viral STI almost total STI line and viral STI is almost the same, but later on viral STIs are bacterial STIs are on the rise. So this is a trend of syphilis. Initially in 1998, the blue line shows syphilis over 20 years among patients in tertiary care. It's black line represents the trend line, which initially it was on the rise, and slowly a dip was seen, and gradually it is increasing. And this is again another study from Trivandrum Medical College by Dr. Pradeep Nair, a study of changing trends, the pattern of STI infections in state of Kerala. So in 1996 to 2000, syphilis was 515, and 2001 to 2005 it was 469. And later on the HIV was 97, but recently after 2000 HIV is on the rise, hepatitis B is on the rise. And now the trend of STI is, that is 2021, 3.9 crore patients globally are HIV positive, whereas 24.1 lakh in India are HIV positive. Of that, 0.13 crores are new cases in globally, and 69,000 new cases in India. And our statistics in GMCE, that is from Pulleri Clinic in our department, which was started in 2009. From 2009 to 2019, there were 43 cases. Of that, 38 were males, 5 females, and no transgenders. But in 2020 to 2024, that is post-COVID, that is mainly data is from 2021, almost 121 cases of syphilis. Of that, 114 were males, 4 were females, and we had 3 transgenders. So genital ulcer herpetic, it was 23, and from 2020 it is 15. And vaginal discharge 217, it rose to 710 recent years. And genital warts on the decline, that is 22 and 13, but the number of years are less here. Urethral lower abdominal pain, 24 patients, now recently it is 45 patients. Urethral discharge is on the rise, that is bacterial STIs, mainly syphilis and gonorrhea are rising. There is a trend now which we see in our college, but which is contradictory to the global and Indian trends. So this is a case which we published from our department, that is coexistence of multiple sexually transmitted infections in an HIV negative patient. So this patient was a migrant laborer, came with 4 sexually transmitted infections, but HIV was negative. So he came with dysuria and pus per urethra. So you can see the white thing that is coming from the urethral orifice, that is purulent discharge, and he had an ulcer in the second picture, that is a primary chancre. So gonorrhea, primary chancre, and you can see the papular eruptions on the penis, that is papular genital warts. So gonorrhea was positive, that's a Gram-Stein smear in the colonies of gonococci, and he was HCV positive, anti-HCV was positive. So 4 coexistent HIV infections in a migrant laborer, STI in a migrant laborer who was HIV negative. Usually we see infections as STI along with HIV, but this is this patient was a bisexual with injectable drug use. He was an IDU also. So maybe that is why he got a HCV positive. So that shows the importance of this case was seen in 2021, that is post-COVID. And this is another article from Indian Journal of Sexually Transmitted Disease and STI and AIDS. The new STIs are emerging, that is non-classical STIs spread by sexual contact, such as Shigella soni, hepatitis A, Neisseria meningitis, Zika and Ebola are on the rise, and re-emergence of STIs like lymphogranuloma venereum, which we never used to see, but we are getting cases with and increasing Mycoplasma genitalium. These are the new emerging STIs. These are usually common in men having sex with men. So factors that increase the risk of transmission, there are different factors. I'm not going into the details of all that. Behavioral factors, very important, because personal sexual behaviors, not using condoms during penetrative vaginal, oral, anal sex, because they say that it is safe for anal and oral sex. So we see youngsters who are homosexuals not at all using protective measures when they have oral and anal sex, and frequent change of sexual partners, having more than one sexual partner, having sex with casual partners, and sex workers. Nowadays, sex workers, because of the projects which are run by the Kerala State AIDS Control Society, they are well aware, and every 3 months they come for checkup and they have presumptive treatment also. So others which are not involved in the projects, we have a rise in sexually transmitted infections among these patients. So, previous history of STI, exchanging sex for money, goods or favors, especially as Dr. Preeti told, the children, youngsters are going for studies and work outside, away from home, exchanging sex for drugs and drugs for sex, because group sex is common. So many unnatural practices are prevalent nowadays. And risky personal behaviors like skin piercing, alcohol or other drugs during or before sex, blood transfusion, etc. Then has sex, even if an individual has no risky behavior, they may be at risk if their partners have sex with others, partner has an STI, not taking treatment, partner is HIV positive, partner is an injectable drug user, and has sex with other men. And risky group are adolescent girls and boys who are sexually active and indulging in unsafe sex, women who have several partners mainly for earning money, female and sex workers and their female and male sex workers and their clients, men and women whose jobs force them to stay away from their home or families or from their regular sex partners for long periods of time. Men having sex with men, especially transgenders, because people think that having homosexual practices are safe because they are more worried about pregnancy, so they are not that much worried about sexually transmitted infections. Then street children and prison inmates, especially in community living, homosexual practices are very common, and even sexually transmitted infections are on the rise. So this is our patient with, you can diagnose this, what is this? It's an acute gonorrhea. All these are our patients. Then this is again, this patient had stotal ulcer and ulcer on the penis. It is a case of chancroid. Then this, can anyone say what's the diagnosis? Any diagnosis? Secondary syphilis. This is asymptomatic psoriasiform lesions, especially on the palms and soles. This is very common nowadays. The skin lesions of secondary syphilis are very common because since it is asymptomatic, people may not notice at all and they'll apply emollient, so they just go around without taking any treatment. Again, a patient with STD, if no gonorrhea, the HIV genital viral load will be 19%. Gonorrhea pre-treatment, it is 44%, and post-treatment, it is 21%. That is treatment of gonorrhea. The viral load decreases when STI and HIV coexist. And this, any idea what it is? Asymptomatic genital ulcer. This is primary chancre. You can see the raised border of the lesion. It is asymptomatic genital ulcer, that is primary chancre, because we see lots of cases of primary, secondary, ocular syphilis, throat syphilis, even neurosyphilis. We had patients with neurosyphilis. We don't know whether young MI is due to syphilis or not, because we have to be on the lookout for syphilis now. And this again psoriasiform lesions, it is secondary syphilis plus the mucocutaneous lesions on the penis, condyloma lata lesions. And this is a young boy, a +2 student who came with ulcer on the medial aspect of thigh. On examination, it was hard on palpation, so we did an RPR, it was positive. So this is an extragenital chancre on the medial aspect of thigh in a young boy who was staying away from home for work, and he had he was involved in drug abuse also. So this is a primary chancre on the medial aspect of thigh. Just showing few cases to make you aware that such cases are prevalent now. So any idea what it is? Again asymptomatic. Can you see rash? Rash is there, maculopapular eruptions, bilaterally symmetrical on the anterior and posterior aspect of trunk. This is again papular syphilis. Asymptomatic lesions, nowadays you have to routinely look for syphilis. Again this is another young boy with lesions on the medial aspect of foot and on the trunk. He had both psoriasiform lesions on the palms and soles and papular lesions. Again case of secondary syphilis. This is also, because all these are different patients which we had. Again bilaterally symmetrical, mainly on the instep. This will be seen on the instep. This is again looks like a papular pityriasis rosea. Even if we see asymptomatic lesions on the skin without any fever or any other constitutional symptoms, we have to do a test for syphilis. This again purpura-like lesions. This patient was also RPR positive. Again similar lesions. Then this, anybody? This patient came with some irritation on the throat, but he was a homosexual. So his partner was syphilis positive. So he came himself and told that he want to do a syphilitic test. So when we examined, you can see the white patch there. That is syphilis. This, any idea what it is? This is a patient who was recently admitted. The lesions are healing now with multiple grouped ulcers. It is herpes, perianal herpes also. All these were larger lesions, big lesions, group lesions with necrotic ulceration. So we have to rule out HIV or immunosuppression in such a patient. That is medicine patient who was admitted. So this is again this is condyloma accuminate, perianal lesions, very common nowadays because of anal sex. This again perianal lesions. This is again condyloma acuminata lesions. So this asymptomatic lesions, florid lesions on the face. This is an HIV positive patient, and this is molluscum. You can see the amplification on those lesions. Molluscum contagiosum, so will become extensive and large molluscum with cystic degeneration of the molluscum lesion. Sometimes all this will coalesce to form large lesions. This again in an HIV positive patient with extensive warty papules, verruca vulgaris. So this multidermatomal herpes. Again we have to rule out HIV infection. Even if we see an ophthalmic zoster, have to do perianal herpes, ophthalmic zoster, all this will be associated with HIV infection. So now we are in the NACP phase 5, that is universal access to STI-RTI services for high-risk group, virtual outreach programs for underserved populations, and elimination of vertical transmission of syphilis, distribution of free condoms, and STI treatments. These are the key changes which are being made in the NACP phase 5. These are certain challenges and recommendations because we have to be on the lookout, and we have to think that the patient coming to you might have some of these things, because we can't assess the risk of most of the patients now, especially youngsters, because most of the patients, the statistics of our ART clinic is recently they had about 377 registered cases of HIV infection after the ART clinic was started in 2021. We have 377 cases, of that mostly patients from 18 to 40 years of age, and we see most of them are men, and about 38% are homosexuals. And among this, 38 were HIV plus syphilis. So HIV, syphilis, co-infection are on the rise nowadays, and we see a lot of young patients, and that too homosexuals, coming with STI. And so even if they come with some diarrhea, fever, etc., we have to look for the organism and see, look out for HIV also. So that's in short about few changing trends that we have noticed. Thank you.
Thank you, Deepa, for the insightful talk and for sharing your experiences. And if there is any questions, you can.
STI.
Madam, that is new emerging cases, especially seen in MSMs, when they come with diarrhea, fever, diarrhea and all. Because high risk individuals, this was reported. High risk, they were MSMs, they were reported in MSMs. That's why it was included under, new studies are coming. Even I forgot to mention about monkeypox. That is again another emerging STI.
I would like to kindly request Dr. Preeti to hand over the certificate to Dr. Deepak.
So with that, we come to the end of today's CME. I extend my sincere gratitude to the Department of Dermatology and Medical Education Unit in organizing this event. I thank each one of you for your active participation in today's CME. We hope that the knowledge and insights shared by our expert faculty will enhance your clinical practice and contribute to improved patient outcomes. Once again, thanking you all.